I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down for a 30-minute conversation with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. The consequences of traumatic brain injury, or TBI, can be devastating to mental health and well-being, and can include difficulties with cognition and memory, personality changes, and depression. In this interview, we discuss the most novel neuroscience research on the diagnosis and treatment of TBI with Dr. William Sauvé. After 11 years of active duty service, Dr. Sauvé left the United States Navy to become the clinical director of the military program at Poplar Springs Hospital in Petersburg, Virginia, an inpatient structured program for the treatment of PTSD and chemical dependency that caters exclusively to the military population. In 2014, he left Poplar Springs Hospital to focus on transcranial magnetic stimulation, or TMS, and now serves as the medical director for TMS NeuroHealth Centers in Richmond and Charlottesville, Virginia. Welcome, Dr. Sauvé. I would like to ask you if you could give our audience a little bit of a background on just what post-concussive syndrome, or PCS, is, because we kind of hear that term being tossed around a little bit, and I think sometimes there's a little bit of confusion as to what that means exactly.
And I'm not convinced that I'm going to be able to clear it up entirely, but I think the best characterization I could give, post-concussion syndrome, has to do with a cluster of symptoms following a concussion that I think many people might not even think was really a concussion, and yet several days or weeks later, people can present with headaches, feeling dizzy, confusion, memory problems, cognitive problems, and maybe irritability and mood problems, sleep problems that really come on long after the fact and are probably not even because of the original injury itself, but instead of a cascade of kind of post-injury problems where the brain is kind of literally hurting itself more for several weeks after maybe what was even a little innocuous injury.
I think that's helpful in terms of, just being clear on what that term is. No, really, because
I thought it failed to clear up anything.
No, I think that was great, because I think perhaps one of the distinctions is the fact that it's persistent symptoms, right? And I think sometimes people just think, well, do you mean like my head hurts because I hit my head, Right. So these are pervasive symptoms, and they're really, I love how you tied that in with the biology and sort of the cascade of events that occur following the injury. Somewhat along those lines, would you say that all neuronal injuries are the same, or do they result in the same symptoms?
They definitely don't. And the worst part is there's no way to tell. When it comes to concussions, at one end of the spectrum, you can see somebody who got what they literally think of as a little bump on their head. And if you ask them if they ever had a concussion, they would say no, because they weren't knocked out and they didn't think of it as a big deal. It was just a little bump. And that person can have persistent problems, weeks and weeks later, with all these secondary effects of injury. On the other side of the spectrum, a fighter who's been knocked out multiple times, and as far as anybody can tell, they seem to be completely fine. That cascade doesn't happen in them, even with relatively severe head injuries. And there isn't yet a good way to know, beforehand the difference between the two. I would say that with some emerging lab tests, possible markers, biomarkers, it's like so close I can taste it.
That was actually going to be my next question.
Well, there we go. It's kind of a perfect segue. I'm imagining a very near future where we can be watching a fight and a fighter gets knocked to the mat, and they will have a blood test in the back room, and the results of that test will decide, does that fighter need to start rehab, start certain kinds of active treatment, or are they going to be okay to come back to the ring in a couple of days because they're not showing signs of this potential post-concussive syndrome? Not quite there. Almost.
Yeah, almost. Would you say there are some biomarkers that kind of keep our eyes on in terms of sort of being in development, or where the research shows that they might be useful in terms of what you're talking about, in terms of being able to identify individual differences?
There are. Their tau protein seems to be the biggest one, and then the thing we were just talking about that I couldn't quite remember, that it's not quite so simple as tau just being in your blood, but it might be encapsulated in certain cells. So there's a certain way to look for it, that it might indicate inflammation or not inflammation. And it's kind of interesting that we talk about tau a lot when it comes to dementia. So there seems to be a little bit of cross-pollination there. And then a few other genetic markers. Genetic vulnerabilities are interesting to look at, and that can place people at great risk to have problems after a seemingly small injury.
Wouldn't it be good to know sort of ahead of time what our genetics might be able to tell us if we do experience a head trauma?
Right.
I think that's very useful. What could you say about any sort of special considerations when it comes to pharmacological treatment for psychiatric conditions that are associated with traumatic brain injury? Are there specific medications to avoid, things like that?
There's a couple. Number one, I think the biggest problem after a TBI, even a mild TBI, and I don't like the name mild TBI because you can have it and it's not mild, but that non-obvious injured TBI, the chances of any psychiatric diagnosis being made in the following several years goes up by north of 50% or something like that. So people with a history of concussion and a history of mild TBI can present with anything. It's, depression, PTSD, even bipolar disorders, and in some cases even schizophrenia. So right out of the gate, you're not really looking at particular mental health related symptoms that you would tie to a TBI. Right. These are people who are going to be in emergency rooms with every diagnosis you ever heard of. And then it's up to the clinician to get that concussion history and maybe start putting one and one together that this might be TBI related, and then think about what medications you might not want to use in those circumstances. And in general, it's drugs like benzodiazepines that I just don't want to pour benzodiazepines all over a brain that's already kind of hanging on for dear life. So if the brain is already potentially cognitively impaired and it's already been slowed and it's already had some damage, then something that simply turns that dial down even further and is going to potentially snow somebody's cognition to a certain extent, hurt their impulse control when their impulse control is maybe already not great. Another one that I think really sneaks up on people are drugs that have an anticholinergic property, which would be paroxetine is the famous antidepressant for that, but then all our over-the-counter sleep aids, right, that are usually just one version or another of diphenhydramine, which is a highly anticholinergic drug. And I had a case in the hospital where a patient was told to me every morning that the patient had become psychotic at night. And about the third night in a row, you're trying to figure this out. Why is this person having alleged psychotic episodes always after I go home?
Right.
And I come in the morning and I hear about it, and in the morning she seems fine. And then figured it out that she was being given diphenhydramine at night for sleep. And she wasn't becoming psychotic, she was becoming delirious, with a history of PTSD and with a history of a brain injury. Right. I'm pretty sure I remember she'd been in a car accident. So her brain really couldn't tolerate that one extra hit of anticholinergic poisoning. And we stopped that particular sleep aid and that problem went away. So you can get sabotaged by something that seems, people go to the store and they buy, their something PM to help themselves sleep.
Without
the next thing you know, they're in the emergency room and they're being diagnosed with psychosis. And that's something to watch for.
What would you say about some non-pharmacological treatments? What are some that might be particularly effective for treatments for traumatic brain injury?
Well, number one, you and I are both huge fans of exercise. And the post-concussive syndrome and the secondary injury has a lot to do with inflammation, right? And not 100% well understood. not well known how to modulate that, right? I've already seen some data that if you use steroids to shut down inflammation post a head injury, all of it down, the patient has a worse outcome. So that's not the answer. You can't just completely shut it off. But in terms of one of the natural ways to modulate inflammation in the human body, exercise is probably about the best anti-inflammatory way. and it's 20-ish minutes. I think people don't always get that I'm really talking about 15-20 minutes of very moderate intensity exercise. Right. Doesn't really matter what you do. And so if you like to lift weights, lift weights. If you like to speed walk around the neighborhood, you do that. And that tends to really suppress inflammation for about a day, which is good for a lot of things. But taking that inflammation off the brain is probably a winner. Non-pharmacologic, but sort of pharmacologic, right, is N-acetylcysteine. Yeah. It's pharmacology, but it's over the counter and has been for a million years, and it's so cheap it's basically free, right? So you can go to just about any vitamin store or fancy grocery store and get it. And I always tell people, by the way, if you ask for N-acetylcysteine and the person behind the counter looks at you like you just spoke a foreign language, then say NAC. Everybody knows what that is. It usually says that on the bottle. Right. And the Navy did a great study showing about 4 grams a day, like 2 grams twice a day, within the first 24 hours after a head injury. And there was about an 80+% resolution in post-concussive syndromes versus less than half that when they were using placebo. And what's really neat about that is N-acetylcysteine doesn't really cross the blood-brain barrier. But a head injury transiently makes the blood-brain barrier loose and permeable. So the authors of the study even recognized it's kind of ironic that the injury is what enabled the thing that needed to get into the brain to get into the brain. Because otherwise, N-acetylcysteine is not nearly as efficient at getting into the central nervous system.
Right. And so would you say that might account for the time dependency of its working? That's fascinating.
That's kind of your best window. Yeah. And then the final point, and again, that we've been talking about a lot, a ketogenic diet, which is not a fad, it's not new, profoundly anti-inflammatory. So that there's a lot of interesting science that ketones might be a better fuel than glucose for the brain anyway, and that's fascinating. And it is anti-seizure, which is something you want if you've had a head injury, but another way to take that inflammation off the brain, I think, really helps with a much more conducive healing environment post an injury.
Well, this was spectacular. Thank you so much, Dr. Sauvé, and thank you for joining us on this edition of the NEI podcast.
This podcast was brought to you by NEI Learn. Access all of NEI's CME activities from your mobile device. NEI Learn is available for download on iTunes or Android.